Hi there, dear valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for all healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time as I share with you some very useful tips which may prove handy and very useful in your line of duty. Welcome to part 73 of our pharmacotherapy MCQ series measuring in toxicology. Our first question reads: as the clinical pharmacist on call at your accident and emergency department on a Sunday afternoon, you receive a call from the emergency medicine resident inquiring about the management of metformin toxicity. My question to you is, which of the modalities listed below would you recommend for the management of metformin toxicity? Would you settle for IV sodium bicarbonate? Would you recommend the administration of glucagon? Would you settle for hemodialysis? Or would you recommend the administration of octreotide? I'll give you 10 seconds to choose the correct answer. Both answers A and C are correct. Sodium bicarbonate and hemodialysis may be considered in acidotic patients with metformin toxicity. Now, case reports have shown improved outcomes with sodium bicarbonate with or without hemodialysis in patients with both metabolic acidosis and hyperlactemia. Now, glucagon can be considered initially in patients with sulfonylurea toxicity when IV can't be obtained. It doesn't apply to this case. Now, octreotide, which is sandostatin, is a subcutaneous semi-synthetic long-acting analog of somatostatin. It acts by blocking insulin secretion from beta cells, and it is used in sulfonylurea toxicity. So let's move to the next question, please. And it reads: which of the calcium channel blockers listed below has a long half-life of over 30 hours which isn't related to its dosage formulation? Is it clevidipine, which is marketed as Clefiprex? Is it Amlodipine, which is marketed as Novask? Is it felodipine, which is marketed as Splendil? Or is it nicardipine, which is marketed as Cadine Sustained Release? I'll give you 10 seconds to choose the correct answer. Amlodipine or Novask it is. Now, Amlodipine or Novask has an inherently long half-life of 30 to 50 hours and is not related to the dosage formulation being used, such as extended release or sustained release. Now, clevidipine has a short half-life of 1 minute and is used via IV infusion for acute hypertension. And nicardipine, which is Cadine SR, has a half-life of 8.6 hours, while felodipine, which is Splendid, has a half-life of 11 to 16 hours. Now, amlodipine is a fairly common antihypertensive used in clinical practice due to its favorable pharmacokinetic profile that allows it to be effectively administered once a day, and it maintains its effect on BP. Now, given amlodipine's pharmacokinetic profile, it can be crushed and administered via NG tube without affecting its half-life and even release characteristics, unlike some other agents with short half-life. Let's move to the next slide, please. The equation reads: an ambulance rushes a male patient to your accident and emergency department with a tricyclic antidepressant Toxicity. Now, in the course of this patient's examination, he goes into sustained ventricular tachycardia. My question to you is, which of the modalities listed below would be the most appropriate for the treatment of this cardiac arrhythmia? Would you opt for urinary alkalinization? Would you infuse sodium bicarbonate? Would you administer amiodarone? Or would you settle for lidocaine followed by hemodialysis? I'll give you 10 seconds to choose the correct answer. I would opt to administer IV sodium bicarb. Now, sodium bicarbonate can effectively be used to manage a patient with malignant ventricular dysarrhythmia from tricyclic antidepressant Toxicity, because the higher load of sodium can overcome the blockade occurring due to the ingested tricyclic antidepressant. Remember, key treatment goals of sodium bicarbonate use to get the QRS interval to below 100 milliseconds and to maintain the pH between 7.45 and 7.55, between 7.45 and 7.55. Now, amiodarone has no role whatsoever in this situation and could worsen this patient's clinical status because of its ability to further prolong the QT interval in this scenario, where the QRS and the QT are already prolonged. Now, lidocaine is a class 1B antiarrhythmic that can also inhibit sodium channels and decrease conduction velocity. Hemodialysis will not be effective in the management of tricyclic antidepressant Toxicity due to the large volume of distribution of the TCAs. And urinary alkalinization hasn't been shown to be effective in the management of TCA Toxicity. And sodium bicarbonate can be used to overcome sodium channel blockade in cardiac myocytes from TCAs. Now, increasing the blood pH with sodium bicarbonate is also thought to decrease free fraction of TCA available to bind to sodium channels, increasing the degree of protein during binding the charged TCA molecule in an alkaline environment. Just as a by the way. The next question reads: which of the adverse drug reactions listed below would be of concern when infusing N-acetylcysteine during the management of acetaminophen toxicity? Is it liver toxicity, renal toxicity, anaphylactoid reaction, or hemolytic anemia? I'll give you 10 seconds to choose the correct answer. So anaphylactoid reaction it is. Now, anaphylactoid reaction, including bronchospasm, has been reported with IV N-acetylcysteine, especially when administered too fast via IV infusion. Now, IV N-acetylcysteine treatment is normally 150 milligram per kilo in 200 ml of D5W that should be infused over 1 hour, followed by 50 milligrams per kilo in 500 ml of D5W infused over 4 hours, followed by 100 milligrams per kilo in a liter of D5W infused over 16 hours. So endeavor to stick to the total of 21-hour therapy. Don't push it too fast. Now, none of the other listed adverse drug reactions are associated with NAC, N-acetylcysteine use. Now, N-acetylcysteine is sometimes used by some clinicians for the prevention of contrast-induced nephropathy, just as a by the way. The next question reads, Mr. PLY, a male patient, was found unresponsive in his living room approximately half an hour ago. Next to him was an empty bottle bearing a label of Procardia XL. Despite being lethargic, he is breathing on his own, unassisted. That is, so my question to you is, which of the treatment options listed below would be the most appropriate for Mr. PLY now? Would you choose to infuse calcium chloride? Would you administer activated charcoal slurry? Would you inject glucagon? Or would you infuse sodium bicarbonate? I'll give you 10 seconds to choose the correct answer. I would settle for glucagon. Now, glucagon is commonly used for the overdose of calcium channel blockers due to its ability to bypass normal catecholamine generated influences on cyclic AMP and the fact that it increases CMP via other mechanisms which have been shown to increase both pulse and blood pressure. Now, activated charcoal can be considered in overdose of an intermediate release calcium channel blocker, but it isn't likely to be useful 2 hours after ingestion or in the long-acting agents. Just remember that. I'd also like to remind you that there is very little evidence for use of calcium chloride or calcium gluconate for calcium channel blocker toxicity. So that would not be first line. And then sodium bicarbonate is only considered for use in calcium channel blocker toxicity when the QRS interval is wide. Now, glucagon has been shown to increase both pulse and BP, as I said, in calcium channel blocker toxicity, so it would be superior to all the other three. I would like to emphasize that Procardia XL, which is nifedipine, is a long-acting dihydropyridine calcium channel blocker. Now, since we have to administer glucagon, I would advise you to premedicate the patient with an antiemetic, since glucagon can increase the risks of nausea and vomiting, especially as the dose is increased. So remember that. Let's move to the next question, please. And it reads, Mrs. OJS, a 21-year-old female patient, is rushed to your accident and emergency department by an ambulance following a distress call by her friend after reading a concerning WhatsApp message she received from OJS. Now, OJS is currently awake, alert, and appropriately oriented, though she's tearful, only complaining of nausea. She informs the emergency medicine consultant that she took a few handfuls of paracetamol tablets, about 120 minutes ago. Our vital signs are all within normal limits. Some of our pertinent labs include an anion gap of 11, serum creatinine of 0.8, INR of 0.9, APTT of 26 seconds, and the paracetamol levels are 200 millimoles per liter. So my question to you is, which of the interventions listed below would be the most appropriate in the case of OJS now? Would you administer N-acetylcysteine at a dose of 70 milligrams per kilo IV over 60 minutes? Or would you administer N-acetylcysteine at a dose of 150 milligrams per kilo IV over 60 minutes? Or would you inject ondansetron at a dose of 4 milligrams start IV? Or would you administer N-acetylcysteine at a dose of 150 milligrams per kilo orally start, single dose? I'll give you 10 seconds to choose the correct answer. I would choose to inject 4 milligrams of ondansetron IV start. Now, there is no guideline which provides information regarding interpretation of paracetamol levels less than 4 hours after ingestion. Now, this is a result of variation in absorption and an alpha and beta distribution phases of paracetamol. Now, while starting N-acetylcysteine therapy as soon as possible after ingestion may be considered, it is nearly 100% effective if started prior to 6 to 8 hours after ingestion. Now, paracetamol levels drawn between 1 and 4 hours after ingestion may be helpful, although still controversial to exclude paracetamol ingestion and not to guide antidote therapy. Now, the most appropriate treatment at this time would be ondansetron 4 milligrams IV start, in my opinion. Now, for guiding N-acetylcysteine treatment, only paracetamol levels after the 4-hour mark after ingestion are clinically useful. Now, N-acetylcysteine may be removed by certain high-flow hemodialysis filters. It is therefore suggested that should a patient who is receiving N-acetylcysteine for paracetamol toxicity require hemodialysis, the loading dose should be repeated on conclusion of the dialysis. Now, massive overdoses of paracetamol or acetaminophen have been demonstrated to have multiple peak serum concentrations as a result of delayed gastric emptying, and a prolonged window for gastric decontamination of up to 4 hours is reasonable. Now, I would like to add that iatrogenic overdose of paracetamol can occur as a result of concomitant paracetamol co-formulated products. Somebody could be taking the tablets as well as flu remedies, and this can lead to such iatrogenic overdoses. Just as a by the way, let's move to the next question, please. And the next question reads, which of the ECG changes listed below would be seen after digoxin toxicity? Would it be sinus tachycardia, scooped ST segment, normal sinus rhythm, or bundle branch blocks? I'll give you 10 seconds to choose the correct answer. Scooped ST segment it is. Now, a classical sign of digoxin toxicity is scooped ST segments. There's also paroxysmal atrial tachycardia with AV needle blocks. Can also observe junctional rhythm, sinus bradycardia, ventricular tachycardia, ventricular fibrillation, or even bradyarrhythmias. There is a wide variety of dysrhythmias seen on the ECG with digoxin toxicity due to conduction delays and increased automaticity. Let's move to the next question, please. The next question reads, Mr. GOS, a middle-aged male TB patient who is on TB treatment, also has a major depressive disorder, and he presents to your accident and emergency department with an intractable seizures which don't respond to lorazepam. My question to you is, which of the options listed below would be the best next course of action in Mr. GOS case now? Would you opt to administer desferoxamine, phenytoin, pyridoxine, or would you opt for hemodialysis? I'll give you 10 seconds to choose the correct answer. I would administer pyridoxine. Now, pyridoxine replenishes B6 levels and is given if a patient is on isoniazid and has a seizure. Now, this is the only case where a vitamin is the only treatment for a seizure. I would like to remind you that phenytoin will not be effective in a patient who is having a seizure while on isoniazid. Don't waste time administering it. And then desferoxamine chelates iron to make it more water soluble, and it can be passed out with the urine. Now, pyridoxine is recommended when slow acetylators are taking isoniazid to prevent neuropathy, as well as in cases of seizures in patients taking INH. Let's move to the next question, please. And it reads, Mr. PLR, a 36-year-old male patient who swallowed 90 tablets of oxycodone co-formulated with paracetamol approximately 6 hours ago, is now rushed to your A&D department. So my question to you is, how would oxycodone potentially affect paracetamol pharmacokinetics? Would it lead to rapid peak absorption of acetaminophen? Would it lead to delayed peak absorption of acetaminophen? Would it lead to induction of CYP2E1 and increased production of NAPK? Or would it lead to delayed metabolism of acetaminophen? I'll give you 10 seconds to choose the correct answer. Delayed peak absorption of paracetamol it is. Now, agents that slow gastrointestinal motility, such as anticholinergics, including diphenhydramine or opioids, will cause a delayed peak absorption of paracetamol or acetaminophen. Now, as a result, caution should be taken in the interpretation of paracetamol levels, and should consider the patient's clinical assessments and other liver enzymes and liver function tests. Now, IV paracetamol is theorized to be less toxic than oral paracetamol. Now, oral absorption provides a high concentration to the liver via fast pass circulation compared to dilution and distribution from the IV administration prior to the drug reaching the liver. That's just a by the way. Let's move to the next question. And it reads, which of the concerns listed below would arise in a patient intoxicated with metformin? Would it be liver toxicity, fluid overload, metabolic acidosis, or hypoglycemia? I'll give you 10 seconds to choose the correct answer. Metabolic acidosis it would be. Now, metabolic acidosis is of concern with metformin toxicity due to impaired metabolism of lactic acid by the liver. Now, fluid overload and liver toxicity are of concern with the TZD toxicity, not metformin at all. Now, first generation TZDs are known to cause some liver problems, but they are no longer in the market, so that should not be a worry to you. And then the sulfonylureas increase insulin secretion, therefore hypoglycemia is of concern with SU toxicity. Now, while metabolic acidosis with hyperlactemia is rare, it can occur in metformin overdose. Remember, metformin inhibits hepatic gluconeogenesis from pyruvate, which decreases hepatocellular pH, causing a reduction in lactate clearance. So if an impairment of inoxidative metabolism is present, such a patient can present with metabolic acidosis as well. Let's move to the next question. Our last question reads, Lady ALK, an 18-year-old female, swallowed 80 tablets of diphenhydramine 3.9 hours ago, almost 4 hours ago. Currently, she is confused, agitated, and flushed. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Madam ALK now? Would you administer pyridostigmine, atropine, physostigmine, or scopolamine? I'll give you 10 seconds to choose the correct answer. I would settle for C, physostigmine. Now, diphenhydramine overdose can manifest as an anticholinergic toxidrome, which includes agitation, mydriasis, dry mucous membranes, flushed skin, and hyperthermia. Now, under the guidance of a toxicologist, physostigmine can be used as a therapeutic agent or as a diagnostic agent. It shouldn't be used if there is suspected or confirmed tricyclic antidepressant overdose. I would also like to add that diphenhydramine has a tricyclic based chemical structure similar to that of TCAs and may cause similar effects in toxic doses due to its antagonistic effects on sodium channels. To be specific, I would like to underscore the fact that physostigmine should be used in small escalating doses to avoid flipping to cholinergic crisis. Be very careful when using it in this scenario. And diphenhydramine overdose can cause a slowing of gastrointestinal motility and a delay in peak absorption. Now, this delayed gastric emptying can expand the window for activated charcoal administration. So you can always use activated charcoal slurry to intervene even if many hours have elapsed. So, ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of this video. Now, if it benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers out there. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. and I thank you very much for viewing it and for listening to it. I sincerely appreciate your partnership, your continued support, and your kind collaboration, and I look forward to interacting with you in part 73 of our MCQ series. Thank you very much.